So thanks for inviting Susan and I to speak today about something that I agree we're both very, very passionate about. So tonight, we're going to be talking about three sort of broad topics. First, I'll do an introduction about the status of cancer survivors today, numbers and what cancer survivors look like. And then we'll discuss how cancer and cancer treatment can impact physical fitness, and in particular strength and function, and then with a major focus on cardiorespiratory fitness. And then finally, we'll introduce a model that we have here for providing exercise and rehabilitation to cancer survivors. So to start, there is an increasing emphasis on cancer survivors for one very important reason, and that is that there are a lot of cancer survivors around. According to the American Cancer Society in 2012, that should be 2012, there were 13.7 million cancer survivors, and that number is growing. It's expected to be 18 million in the year 2012. However, back in 1973, that number was 3 million, so you see that we have had a lot of increase in the number of cancer survivors, and that's for two main reasons. We have better treatment, so people are living longer, and we also have better ways of identifying cancer early. And so that's given us the opportunity to consider now the impact of our cancer therapy on people's lives as they live many years beyond their cancer diagnosis. So just a brief snapshot of what a cancer survivor looks like right now. 64% of adults with a cancer diagnosis are expected to live at least 5 years after diagnosis. That's almost 2/3. 61% are over the age of 65, and I think that has important implications when we think about physical fitness of cancer survivors. And of that pool of cancer survivors, the majority are breast cancer survivors at 22%, followed by prostate, colorectal, and then there are many other types of cancer survivors as well. And then another important point is that 50% have late treatment-related effects, so they still feel that they have impacts from their cancer therapy. So if you think about cancer treatment, many individuals go on for quite some time, probably with cancer on board, and they don't know it. And then either they're screened and it's identified, or perhaps symptoms develop and it's identified. And then individuals face this whirlwind of treatment effects. So they get their diagnosis, they have a biopsy taken, they potentially have surgery, they potentially have radiation and or chemotherapy. So it's a very multimodality treatment that's required for most cancers. And so just briefly, some impacts of surgery and radiation. There are many more. I just am a medical oncologist, so I tend to focus more on that. But with surgery, there's impaired range of motion. Obviously, if you're doing surgery in an area that might impact somebody's mobility. Lymphedema associated with breast cancer treatment and axillary dissection. Impaired organ function. I mean, if you're going to take out part of a lung, that's obviously going to impair organ function. And with radiation, there's fibrosis of tissue that can occur with radiation. And this is something that can occur late term as well. It's not something that just happens right at the acute time of radiation. There's also pulmonary and cardiac dysfunction and potential cognitive changes, in particular with whole brain radiation. And I'm a medical oncologist, and so this is what I'm most familiar with, is the acute medical impacts, the acute impacts of medical oncology therapy, which include fatigue, which is by far the most common side effect of cancer treatment, deconditioning, sarcopenia, which is essentially loss of lean muscle or lean body tissue, usually in association with an increase in adipose tissue, cardiac and pulmonary dysfunction related to some of our drugs, nausea and vomiting, anxiety and depression, pain, cognitive impairment as well, or chemobrain. And then those are acute side effects, but then there are lingering or late-term side effects related to our medical oncology treatment as well, including fatigue, which for some individuals can linger for many, many years, functional impairment, and range of motion issues. Lymphedema can occur in the early stage after surgery or can occur many years later. Weight gain and muscle loss, again, related to that sarcopenia piece. Cognitive impairment, diminished body image, heightened anxiety and depression. And there are many treatments available for some of those latent lingering effects. But to me, what's really exciting is that exercise can potentially mitigate all of these. So there's research to support the fact that exercise can decrease fatigue, improve lymphedema, or at least prevent it from progressing, that it can, is associated with improved cognitive function as well, improves body image, decreases anxiety and depression. So exercise is a way to attack all of those. But the one that we're really going to focus on tonight is the latent long-term effect of cancer and its therapy, and that's aerobic capacity, strength, and function, and how exercise can mitigate that. So that's the one that we're really going to focus on this evening. So I'll be talking about the strength and function part of cancer treatment and how exercise can help with that. So you can think about physical fitness as being a component of 5 aspects. So it's not just aerobic or cardiovascular, it's not just strength training. It's a combination of all of these things, including body composition, cardiorespiratory fitness, muscle strength, muscle endurance, how long you can keep up a muscle-related activity, and flexibility. Tonight we're really going to focus on cardiorespiratory fitness and muscular strength. So before I get into much about the strength piece, and this is something that's not in your handout, I just wanted to show you some of the equipment that can potentially be used for this. So on the right-hand side of the screen, that machine that looks like a torture device where you strap people into it, that's a dynamometer, and it allows researchers to be very precise about the range of motion through which a joint goes, and to very precisely measure how much resistance or torque is occurring at different points within that range of motion. So you can get a lot of data from that. But you can also get a lot of information from something as simple as a 1 repetition max. So the 2 areas of the body that we focus on most for 1 repetition max is a leg press, which is at the top. And a 1 repetition max requires an individual to push that weight through a full range of motion at a resistance where they could only do that 1 time. So the top is the leg press, and the bottom is an example of a chest press. So these are just different ways to get at that strength information. So in terms of strength, there is a surprising lack of data out there about how cancer and cancer therapy impacts strength itself. And that's surprising to me because we know that chemotherapy impacts cardiac function, and the heart is a muscle. And we also know that fatigue is a really common side effect. So it surprises me a little bit that there's not more data. But this is information from individuals with glioblastoma or brain tumors. And they in this case, they did knee flexor strength and knee extensor, so extending and flexing at the knee joint. And they measured that before surgery for glioblastoma, and then after surgery, which with about 12 weeks of chemotherapy on board as well. So it didn't take them from diagnosis to totally post-treatment, but within approximately 12 weeks of therapy. And there was a significant decrease in knee flexor strength before and after surgery and chemotherapy, and knee extensor strength. And I think what was more interesting is that compared to normals, now these were generally young individuals who were healthy and walking around just fine, doing all of their usual activities before they were diagnosed. But compared to normals, after they had their treatment, they were 25% lower than what would be expected for normal individuals. And I put this slide in because I wanted it to be a reminder to tell you that it's not just our chemotherapy when we think about medical oncology interventions that can impact strength. And this is a projected trajectory of muscle change in prostate cancer patients who are receiving androgen deprivation therapy, another intervention that can have profound impacts on muscle strength. And so what these researchers identified is that over time, if you followed out musculoskeletal fitness, over time, the individuals on androgen deprivation therapy in the dotted line fell off the normal curve by quite a bit, and that they reached a level of sarcopenia or lack of muscle tissue where they're at risk for disability a lot sooner than individuals who are normal. So in a sense, you can kind of think of cancer treatment as potentially accelerating the aging process a little bit, and I think that's an area of interesting research in the future. So strength is definitely impacted by our medical interventions, but can strength improve with exercise? And the example that I'm going to provide is a transplant example. So these are individuals who are receiving autologous transplants. In this case, it was for hematologic malignancies. So arguably a very challenging process of chemotherapy and treatment to go through. And so what these researchers did is they wanted to determine the impact of an autologous transplant on aerobic capacity, strength, and body composition. So after the transplant, and then what they did after the transplant is randomize those individuals to receive chemotherapy or not, or they did not receive chemotherapy. And so they were able to evaluate the effect of the transplant and the effect of exercise. And this just sort of is a schema of how this happened. So pre-transplant to post-transplant, they had baseline measures taken, and then at the post-transplant time, when they'd recovered their hematologic function, so they weren't neutropenic anymore, their platelets are more normal, they were randomized to receive exercise or not. And the individuals who, and the exercise intervention, was 12 weeks, and the aerobic piece was 3 times a week, started out with 20 minutes, increased to 40 minutes, and it was either a treadmill or a bicycle. And the strength training was resistance training also for twice a week, also for 12 weeks. They started out with low weights but high repetitions, and then moved to a more traditional higher, lower repetitions but higher weights. And so what they found with the first set of bars, I think there is there a light on this? Oops. Well, the first set of bars where it says transplant, what happened there is at baseline, the baseline strength is in the light blue. In the darker blue, that was the impact of the transplant on strength. So you can see it was significantly lower.
Sorry. Help me. Sorry.
Oh, that's okay.
There's a pointer in there somewhere.
Now I can't make it go back, though. Oh. No, I can. Okay, so there was a significant decrease in strength after the transplant. And then after 3 months of recovery on their own, so they weren't in an exercise program, there was still a significant decrease in strength. So even after 3 months beyond the transplant, they had not recovered their strength at all. Whereas if individuals after transplant were randomized to an exercise intervention, they did significantly increase their strength, and they increased it to a point that they were stronger than they were even before they went into the transplant. And that's not too surprising if you think about how much an autologous transplant patient goes through. Most of those individuals who have already had a significant amount of chemotherapy before they even enter into transplant. So the strength piece significantly improved. They also improved their cardiac capacity, and they had more lean body mass as well. And so if everybody went into cancer treatment as, with the muscle strength of a muscle builder or something like that, none of this would matter. But what matters is if individuals go into a treatment and their muscle strength perhaps isn't so great, or if it's a little bit below normal, then what then is the impact of cancer therapy on those individuals. So you can sort of think about it this way, that cancer and cancer treatment is associated with diminished physiologic mechanisms supporting physical function, which can lead to decreased cardiovascular fitness, decreased strength, impair physical function. This is those simple things like taking the stairs or doing activities of daily living, which can then also impact morbidity and mortality. But there can be modifiers in that process, including what an individual brings to the table at the time of cancer treatment, their individual capacity and reserves, their weight, body mass, and diet, but also exercise. And so does the function piece really even matter for cancer survivors? This is a study that looked at elderly women in Iowa. And they followed them for 15 to 20 years, depending on when they entered into the study. And they asked about simple physical function information, and they asked a lot about a lot of health information as well, including whether they had a diagnosis of cancer through this longitudinal process. And there's like 5,000 individuals in this study. And so in the gray bar are individuals without cancer. And I just picked out 3 typical function things that people should be able to do. So, and the average age at the time of this reporting was 71. So the average age of these individuals was 71. So 18% of those 71-year-olds who didn't have a diagnosis of cancer were able to walk, were unable to walk a half a mile. However, if someone had a diagnosis of cancer within 2 years, it was 33% of individuals who could not walk a half a mile. And then if you take it to a function that is less strenuous, just taking the stairs, about 5% of individuals at age 71 without cancer had problems taking the stairs, but this increased to almost 10% if someone had a cancer diagnosis within 2 years. And the same thing for something as simple as preparing meals. It was 2% for individuals who didn't have cancer and almost 5% if they did have cancer. So you can imagine that if someone is not able to prepare meals or has problems taking the stairs, that could impact their ability to stay at home and be functional. But does that have an impact on survival? And it turns out that it potentially does, that individuals with lower physical functioning skills, simple things like walking a half a mile or being able to take the stairs, is associated with greater or lower survivorship. So this is a graph looking at individuals with breast cancer over time who were in a large study looking at the impacts of tamoxifen. And they asked about physical function. And if individuals reported physical function deficits, like they couldn't take the stairs or they couldn't prepare a meal, which is a pretty severe one, if they mentioned even one physical function deficit that was still present at 27 months, they were less likely to be alive at 3,000 days. So you can see that the difference between the dotted line and the solid line at a proportion of surviving of 60% is about 2 years. So individuals who reported just even one deficit were less likely to survive. So that's the strength and the function piece, but arguably a very important piece that supports all of that is cardiorespiratory fitness, and so Susan's going to talk about that next.
Thanks, Kim, and thank you for the opportunity to talk today and for y'all coming out at this hour to hear us speak about what we're really passionate about with exercise. But, you know, I am a cardiologist, but, you know, one of the things that I've thought about my entire career is how can we ever prevent someone from having a heart attack? And now I think about how can we ever prevent someone from ever having cancer? And if they do develop cancer, how do we prevent the complications related to cancer so that they live longer and free from dying from cancer or dying from the competing causes of cardiovascular disease, which are a real issue in cancer-related care? And the thing that really drives me is thinking about what things that we have control over, and one of those things is physical activity and fitness. And so I'm going to share with you the data that supports these statements about being physically active and being fit and how that really impacts our long-term health. It might seem, you know, that exercise is a good thing. We should just do it. But, you know, this has been a turn of events over time. In the 1800s, it's actually thought that exercise is dangerous in healthy populations. So college sportsmen shouldn't undergo vigorous activity because they're not going to live as long as individuals that don't do sports in college. This was going throughout the 1800s, and it was thought that one should not be physically active. It wasn't until the 1950s that we really had a change of events about physical activity and longevity. But this is important because we've had this mindset over time that, well, maybe physical activity isn't something that we should do. Or when that was accepted, physical activity is dangerous in patients that have had a heart attack because they might have another heart attack. We know that's not true. And one of the things that we're really trying to drive forward is, was physical activity and fitness something that a cancer patient should do? Or is it important to prevent the diagnosis of cancer? So while we take for granted that physical activity is something that we should do, it's not always been true. It's now true for a healthy population, it's true for a cardiovascular population, and now we really need to drive home what is the data about physical activity and fitness in a cancer population. And I want to share with you some of the evidence as we move forward. I had to actually go to the library and run this off. It wasn't on, it wasn't like I could get a PDF on the computer. And actually, medical students don't even know how to go to the library and run things off anymore. So I actually had to teach one of my medical students how to do that the other day. But I went to the periodicals, and I went to this very, very famous study by Jerry Morris in 1953 that was the very first study that turned things around, that maybe we should be physically active and it would reduce the risk of having heart attack. And I really want to have a pointer. Oh, good, I have one. Okay, so what he showed, he's an epidemiologist at the time, what he showed in England was that drivers that were inactive, so you had people getting tickets, the conductors, they were walking up and down in the buses, they had a lower rate of heart attack, this in the dark bar, compared to the drivers, the guys that were sitting around not doing anything. Then he did another study where he showed that postmen that were delivering the mail, their incidence of heart attack in the dark bar here was lower than the men and women, probably more women in that day, on the answering the telephone, not doing anything. So we know from this study that just doing something, being physically active in your work, reduced heart attacks. And this was a huge study that came out. And subsequent to this, done in the 1950s, we had other studies, not just whether or not your activity at work would prevent you from having a heart attack, but what about if I go running? What about if I do more vigorous activity, independent of my work? And subsequent studies came out that you would live longer, that you would reduce your cardiovascular mortality. So we had evidence back in the 50s all the way to the 1990s and beyond that being physically active and even vigorous activity was protective. Then, more recently, we have data that physical activity was going to help in patients that had a diagnosis of cancer. This is a very important study that came out looking at physical activity and the rate of reoccurrence from cancer and death in about 3,000 women over time. They collected information about what they were doing with their physical activity. And what it showed was if you spent more hours per week, you had a lower rate of breast cancer reoccurrence, a lower rate of breast cancer death, and a lower rate of total death. So that's great. Physical activity prevents cardiovascular disease, it prevents cancer, it prevents cancer reoccurrence. Great. So what do I tell my patients? Or what do I tell patients that feel like they might be at risk for cancer? Well, one of the issues about physical activity is that a lot of times it's captured when we study this by asking someone, well, how much physical activity do you do? How often do you do it? What kind of physical activity do you do? How long have you been doing it? You can imagine when those questions are asked to you, even when they're asked to me, I really don't give that accurate of answer. Maybe I don't want people to know how much physical activity I do. Maybe I can't remember. And so there's a lot of variability in the response of how much physical activity you do. It's sort of like if I think that physical activity is a good thing, then I should be more specific about what type or how much physical activity I should do. Let's take another risk factor, for example, in the cardiovascular literature. Cholesterol. We all know that cholesterol is bad, right? We want to lower our cholesterol. I bet most of you in the room know what your cholesterol is, and if you don't, you should, because I'm a cardiologist and your cholesterol should be lower. But the point is, no one asked you, well, how much nuts do you have, or how much fiber do you have in your diet to kind of estimate your cholesterol? No, they don't estimate what your cholesterol is. They measure your cholesterol, and they say, your LDL cholesterol is 200, and that's way too high. Well, that's the same thing for physical activity. Should I just say, well, what kind of physical activity are you doing? How often are you doing it? No, I want to measure your physical activity exposure. And that's why I'm a big proponent of measuring someone's fitness. It's totally different but complementary to physical activity. It's objectively measured. I asked you to get on a treadmill. And it reflects not just how much exercise you did yesterday, but how much exercise you've been doing over a long period of time. And it allows us to test what the integrative ability of your cardiopulmonary, your heart and your lungs, to deliver oxygen to your muscles and to other vital organs. We get someone on a treadmill, or we get them on a bike, and then we can report to you your fitness level, just like we can report to you what your LDL cholesterol is. Clinically, it might be someone says, well, you went on the treadmill for 10 minutes. And then you say, well, I want to get better than 10 minutes. Or I want to go better than 15 minutes. Most likely, if you've ever had an exercise tolerance test, they'll say, well, you achieved 9 METs. Well, what in the heck is 9 METs? Well, I'll give you an example. When I sit here and I'm watching television, that MET is 1. My metabolic equivalent is 1. I'm not doing anything. So when I get on the treadmill and I go as hard as I can until exhaustion, if I go 9 METs, that's 9 times more powerful than sitting in a chair. So if some doctor says to you, you achieved 9 METs on a treadmill, you know you did 9 times better than sitting in a chair. So that's one way that we report what your fitness is, or we can tell you how long you did on the treadmill. But the point is, it's measurable, it's reproducible. I can tell you how well you did today on that treadmill, and I can compare you to another population and say, your fitness really sucks. You need to do better. Or I can tell you that you did great. I mean, it just depends. But I have something tangible that I can really move forward with to give you recommendations. Well, hopefully I've sort of differentiated physical activity and fitness on a treadmill, which I really love to measure. But what I want to do now is prove to you that we should measure fitness. Is it better than measuring, just asking someone what their physical activity is? And there's some very, very good data for fitness. And this was one of the biggest studies that came out back in 2002 on fitness. Again, when I talk about fitness, when I talk about METs, when I talk about time on the treadmill, that's fitness. And these are all studies that measured fitness. They got someone on a treadmill and said, how long can you go and how well did you do? So this was from New England Journal, which is probably our top journal that you could possibly get published in. And these were guys that they were going in for a treadmill test. Now, there was a reason. Their doctor said, well, I'm worried about you, and I want to see if you have heart problems. And so they took guys that didn't have heart disease, and they took guys that did have heart disease. And I'm saying guys because it actually was guys, it wasn't women. And they said, if you went 13 METs, so 13 METs would be 13 times greater than sitting in a chair, or 10 METs if you were someone with heart disease. If you did any worse than that on the treadmill, you had a higher risk of dying in 5 years. A 4-fold higher risk if you really did bad on the treadmill. This was the first definitive data in 6,000 people that said that fitness predicted how long you lived. Well, we need data in women, of course. I'm a woman. I study cardiovascular disease in women. We understudy women in most population studies. This is a great study that focused on healthy women, did the same thing. Put them on a treadmill. How far did they go? What med level did they achieve? Did it predict how long they lived? And it did. So this is showing that this black curve is women that are basically the highest fit people. They went on the treadmill longer than anyone else. Over a 20-year period, their mortality was 2%. If you got on a treadmill and you're a woman and you did very poorly on the treadmill, less than 5 minutes, you had a 30% mortality rate at 20 years. Well, that's a huge difference. That's really powerful when I go to talk to my patients and I say, man, if you don't go very long on the treadmill, you have a 30% chance of dying at 20 years. So it's becoming it was a very good marker in women as well. We also did this in terms of lifetime risk. So you say, okay, well, a man or a woman, the time they achieve on a treadmill predicts their survival short term, but how about long term? How about if I'm 55 right now? Does my time on the treadmill predict how long I live to 85 or 90? This study says yes, this is in both men and women. Low fit individuals, meaning they didn't do well on the treadmill, they had a lifetime risk. So 55, the chance of them dying at 85 was 30% versus 8%, 10% if they were high fit. So lifetime risk is reduced if you're fit in middle age. I'm calling 55 middle age. So then I wanted to do another study. This study was, and I get this question a lot, I'm healthy, I'm thin, my cholesterol's good, I'm doing everything I need to do. I don't need to be fit because everything else is fine. I get around, I do the things that I need to do. Does fitness really predict whether or not, how long I'm going to live? So I undertook this study in a group of individuals. Actually, this was done in 40,000 people. And I looked at whether or not fitness predicted their outcomes or told me how long they would live. And what I can tell you from mortality, cardiovascular, and I didn't put up this slide, but I also looked at cancer mortality, that being fit in middle age, even if all your other risk factors are good, helped you live longer from dying from cancer or cardiovascular disease. So then we're here to talk about cancer specifically. And hopefully I've shared you some data that fitness and doing a good job on the treadmill predicts, overall cardiovascular survival. How about cancer? Because as I showed you in the beginning, we had said that physical activity was helpful in patients to prevent cancer or cancer reoccurrence. How about fitness? Should we be measuring fitness in this population? Does it help? So this is a new study that's coming out. It's actually going to come out in press. Well, it's going to come out from an abstract tomorrow, talking about fitness and cancer risk. And so, as I stated, little is known about fitness in cancer. And so we took 17,000 men that had a fitness test when they were 50 years old. And we said, if you take a man that's 50 years old, you do a fitness test on them, you see how far they can go on the treadmill, does that predict whether or not they're going to get lung cancer, prostate cancer, or colorectal cancer at the age of 65? We did this and secondly, we said, does it also predict how long they live after they develop cancer? This slide shows basically that fitness protected men against colorectal and lung cancer, but it did not protect against prostate cancer, which is very interesting. We could go into why that is after we finish this presentation. I have some thoughts about that. But just so you know, our fitness in middle age as a man helped against preventing colorectal and lung cancer. Importantly, though, of the men that did develop prostate cancer and or colorectal and lung cancer, their fitness kept them living longer. So even though they developed the prostate cancer diagnosis, being fit in middle age kept them living longer overall. This is just showing that as a global slide. We don't have to get into the details. And then if we looked at cancer and cardiovascular mortality, fitness protected against both. And these were men that developed cancer. So some men don't die from cancer. They die from other things. So we want to know whether or not being fit in midlife is going to protect from the two major causes of death, and it did. And this is after adjusting for physical activity and smoking and BMI and all these things that we think about are risk factors for cancer and dying from cancer. Above all those things, going longer on the treadmill for a man told us that you were going to live longer after your cancer diagnosis. Well, we don't have that much data on women. That's the next study that I'd like to do. We do have data on fitness and dying from breast cancer. This is a study done many years ago, well, actually only 3 years ago, looking at 14,000 women and whether or not low fitness was a bad marker of survival from breast cancer. And this demonstrates that finding. We need more data on fitness in women and cancer, though. So the next question is, okay, you have now told me that fitness is important to measure. It tells me whether or not I'm going to develop cancer, in a sense, or live longer from cancer. So what determines my fitness? What can I modify to get more fit? Well, the first thing is that our weight really determines our ability to fit. You can imagine me and then someone next to me that's carrying 30 pounds. Do you think the person carrying 30 pounds is going to go as long on a treadmill as someone that doesn't have 30 pounds on their back? No. Weight is a big determinant of our fitness, and this is just showing that it's basically as you increase your body mass index, and that's just your body weight based on your height, that your ability to go on the treadmill, that's in seconds, goes down dramatically. So our weight impacts our fitness. And this I controlled for age because your age changes with your weight, so I wanted to make sure we didn't have that as an issue. This is true across different races, and the more weight you gain, the lower your fitness. So you can see in the more darker black bars, for men and women, Caucasian and African American, if you gain greater than 20 pounds, and this was over 18 to 30 years, which is not unexpected, a pound a year, you lose over 100% change in your fitness. So our weight change, our gaining weight as we age, impacts our fitness. Well, what can we do if we can maintain our weight, we can lose weight? How about our physical activity and the intensity of physical activity to improve our time on the treadmill? So this is looking at women in the red bars, men in the blue bars. This was done in 35,000 people. We measured physical activity and fitness. And down there is this, what we have in the Cooper Clinic where I study this, the physical activity index. So 0 would be they're not doing physical activity. This is specific for running. Then I see 1, they're doing some non-running activities. They might be doing some swimming and that kind of thing. 2, they're running 10 miles a week. 3, they're running 20 miles a week. 4, they're running more than 20 miles a week. as you increase your running activities, you increase your fitness. Now look at this. For a man, if they aren't doing anything, their average MET level was about 7 versus 12 if they were running more than 20 miles a week. That's a 5 MET difference. I mean, that's amazing difference. Physical activity intensity impacts our fitness. Now, this is a pretty cool slide, but the next one is more, really just blows my mind. So I'm going to spend just a moment explaining this. This is a very famous study that came out of Dallas. I was not involved in it, but the individuals that were involved with this study mentored me in Dallas. And so they took just 5 people. I think there's no other 5 people in the world that would probably agree to do this study. That's probably why. They took 5 people in 1966, and they said, you're going to bed. You're going to bed for 30 days. No, actually 3 weeks. They couldn't do anything. They had to sit in their bed. Now think about all the chronic conditions where people have to be in the bed. But these were healthy people, and they said, you have to go to bed and you can't get out of bed. We'll give you your food. We'll give you everything you need. You cannot get out of bed. And they did that. And after 3 weeks of bed rest, maximal oxygen uptake, that's the same thing as fitness, so it doesn't matter, it's all relative. They lost their fitness in 3 weeks, which is hard to do. Then they said, okay, I'll see you in 30 years, do whatever you want. All right? And so those people went back to being active and doing their thing, but they aged. They were 30 years older. The cool thing about this study, what does it show? 3 weeks of bed rest does the same thing to your fitness than 30 years of aging. What does that tell us? We can't be sedentary. Because if we're sedentary and we don't do anything, we lose our fitness very quickly. What does it also tell us? It tells us that individuals that have chronic conditions that keep them in the bed, we need to be helping them get out of bed and be more physically active. Powerful study. 5 people. In the best journal in cardiology. So, where am I going? I got so hyped up about that slide, I don't even know what I'm talking about anymore. All right, so now we're going to talk about, we talked about preventing the diagnosis of cancer or cardiovascular disease. Now I'm going to talk about a person has a cancer diagnosis. So, we're probably one of the few places in the country that actually measure fitness in a cancer population once they have a diagnosis, and this is why. Because there are several things that are hitting a cancer patient at the same time. They come into a cancer diagnosis with existing risk factors. Maybe they weren't exercising before they came into a cancer diagnosis. Maybe they're overweight or obese, and we know that that impacts survival. They're getting all these exposures that impact their ability to be active, their ability to do their daily living. They impact the heart and their muscle function. And so altogether, they're decreasing their cardiovascular reserve, which increases their cardiovascular risk and their cancer recurrence. And so, as a cardiologist, everyone in the country that's involved with cancer patients says, get an echo. We'll figure out whether or not they're healthy. Just get an echocardiogram, look at their heart function, and if it's okay, you're fine. I say no, because you know what? The things that led to a cancer diagnosis, they don't just impact the heart. And yes, I am a cardiologist and I am saying this. It's not just the heart, it's the lungs, it's the muscles. All these things, there's a global impact when you have a cancer diagnosis. And here we have pulmonary function, we have radiation, we have systemic therapy. Obviously, we know cardiac function is impacted by certain medications. We have vascular issues, our ability to get oxygen through the vessels. are impacted by medications that are related to a cancer diagnosis, and skeletal muscle function is impacted by cancer treatment. All of these leading to a lower fitness, not just a lower heart function. It's not just about the heart. Now, this is the first data. This was done by my collaborator in Duke. We didn't really even know what a fitness level was in a breast cancer patient up until a few years ago because no one ever measured it. No one thought that fitness was important to measure in a cancer population. So he finally did the study. We didn't know whether they have a lower fitness or not. He shows that right here, that after you're treated for breast cancer, you have a 31% lower fitness level. All right. Some people come back to me and say, well, they lose their fitness, but they'll gain it back. It's no big deal. Well, let me tell you, just going back to that bed rest study that I showed you, this is another example that just blows my mind. Patients after therapy at 50, their average, this is VO2 max, it's the same thing as fitness, it is fitness measured by the gold standard. The number's 20. It doesn't matter what the actual number is. What you should know is if you take healthy controls, a 70-year-old that hasn't gone through treatment has a fitness level or a VO2 max of 19. What does that tell us? Treatment for cancer has aged that patient 20 years in terms of their fitness. This is not just true. Well, I don't really want to go to that. I just told you that. We then said, okay, let's see whether or not it stays. Can they regain it? Do they maintain a lower fitness? And this is a study that just came out, and we demonstrated that women that had been given cancer therapy, surgery, radiation, chemotherapy, they maintained a lower fitness level, about 1 MET, so only 1 MET, but that was maintained for 7 years. So that fitness level is sustained over a 7-year period, and we already know, and I've already told you, that if you have a lower fitness level, even a little bit, that impacts your overall survival. This is new data looking at other types of cancer in women. We don't need to go into it, but again, it states that other cancers also have a decrement in their fitness after treatment. And this is the first study that came out last year that proved the data, not just in a cardiovascular population, but a fitness in a breast cancer population. If it's lower, you don't live as long. So while we could extrapolate from the cardiovascular data on that, we didn't have to. Dr. Jones at Duke actually did the study showing that if you had a lower fitness level, that's in blue, you didn't live as long. So I think it's important to measure fitness because it's an early marker of not just your heart, but other aspects that are important in your functioning. It's a marker of survival, how long you live. And if we know that it's a marker of survival, and we know that we can intervene, I showed you the ways that we can intervene with exercise training, with lowering your BMI, then we can now begin to target interventions to improve fitness during the cancer continuum. This is just showing that we actually do this in all patients that have completed therapy for any type of cancer at UVM. We put them on a treadmill and we measure their fitness. Here we have actually a breast cancer survival. She's getting on the treadmill. I'm monitoring her heart here on the right. I'm looking at her oxygenation status there on the left behind Nate. And we're just saying, okay, let's get on the treadmill. Let's see how far you go. We increase the grade of the treadmill to make it a little bit harder, and over time she'll stop, and then we'll be able to measure what her overall time on the treadmill is. So now I'm going to turn it back over to Kim to talk about how we're integrating fitness and other measures to create a way for Stats Wellness and Onc Rehab. You can go. This is good
Oh, no, I went too far. Went too fast. So I'm going to back up a little bit. So there is evidence from, again, Lee Jones at Duke, suggesting that exercise training for breast cancer survivors can improve fitness after breast cancer treatment. And so this was a meta-analysis of several randomized controlled trials that actually measured cardiovascular fitness. It included 6 studies, 571 patients. And overall, exercise increased, the VO2 max increased by 15%. And so there's been a lot of research on exercise interventions for cancer patients, aerobic plus resistance training, and there are now recommendations for how much cancer survivors should be doing. And these are recommendations specifically for cancer patients, although you'll notice that they kind of mirror what we're all supposed to be doing. And they're from the American College of Sports Medicine and the American Cancer Society, and this is what cancer survivors and the rest of us should be doing on a weekly basis. So what's recommended is planned weekly exercise of 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise. So 150 minutes, and then strength training 2 to 3 sessions a week that include exercise for major muscle groups and flexibility as well. But we're not necessarily doing so well in this particular area. This is an interesting study. This to me was one of those, oh my gosh, we're not doing very well aha moments. And this looked at individuals who are part of the National Health and Nutrition Examination Survey. This is a study that has been done by the CDC for decades. And what they used to do is they used to just ask people those physical activity questionnaires. How much activity are you doing? But they've stepped it up a little bit in the more recent studies. They go into people's houses and they measure their weight, they measure their blood pressure. It's pretty detailed. And for 4,500 individuals, in a subset of 4,500 individuals in the NHANES study, they had them wear accelerometers. And that's what that picture is there. That happens to be a picture of the accelerometers that we use here at UVM for research. But you strap it on your arm, and these accelerometers can tell movement in 3 dimensions. They can tell ambient temperature and the temperature of skin. And with an algorithm, they can then estimate how much activity an individual is doing. And they're sensitive enough to tell whether someone is lying down or lying down sleeping. It can differentiate between sleeping and just lying down. And so it can also differentiate between whether someone is strolling along, whether they're moderately active or vigorously active. And it's a step up from asking someone how much activity they're doing. And then they wore these devices for 7 days. And so what they found in those 4,500 individuals, so in general, 87.3% of people without cancer in that group did not meet those recommendations of 150 minutes a week. That's pretty dismal. And it's even more dismal for cancer survivors. So 95.5% of cancer survivors did not meet the recommendations for getting 150 minutes a week. And there were some differences by cancer type. So now we're going to move on a little bit to a model that we have here, and that last slide sort of explains one of the reasons that we're trying to do this, and that is to help individuals become more physically active. So I'll be talking about our oncology rehab program, and it's oncology hematology rehabilitation at UVM and Fletcher Allen. We call it Steps to Wellness. And you can sort of think about the cancer survivor continuum in this manner. So an individual is considered a cancer survivor at the time of their diagnosis, and they're also considered a cancer survivor then throughout the rest of their remainder of their life, whether they die of cancer or something else. But the thing about the cancer survivor continuum is that the rehabilitative needs and fitness needs can vary along that track. And so from the time of diagnosis through initial therapy, Our goals are primarily to prevent decline if we can, and therapeutic rehabilitation if it's needed, if someone has had surgery and has range of motion issues, or there's starting to be a fair amount of data about pulmonary rehabilitation interventions prior to surgery to remove a portion of someone's lung, or resistance training for individuals with, who actually have lost weight with cancer, and fatigue management. Exercise in randomized controlled trials is really the only effective intervention for cancer-related fatigue. But our goal would be to preserve cardiovascular fitness and strength and prevent functional decline through therapy. And this is, I think, in particularly important for older cancer survivors. And remember, 61% of individuals that are cancer survivors are over the age of 65. And then there are a little bit different interventions then potentially for individuals in the post-therapy standpoint. So interventions to recondition individuals, to improve aerobic capacity and strength, restore function, lymphedema management, which can be one of those late effects of cancer treatment, again, fatigue management. And we started here in the post-therapy from this post-therapy standpoint, not because we thought it was more important, but because we could. When we first started the program in August of 2011, individuals were worried about whether a cancer patient during therapy could actually participate in this level of activity. And so everything fell in place to have it start in the post-therapy standpoint, but we are expanding it now to during therapy. And there were several things that had to come into place. All stars had to align for this to happen. We had the support of oncology, and physical therapy services had a shift in thinking as well. It always had been thought that, well, if we do physical therapy evaluations on these individuals, we're not going to get reimbursed by insurance. But the leader of rehab, Steve Eiler, said, well, let's just take a chance and see if we can get insurance reimbursement. And so they came on board. And then Phil Ades, that's the picture in the corner, he's the director of cardiac rehabilitation, and he has opened up his arms to pulmonary rehab and to oncology rehab, and he's given us access to the cardiac rehab facilities on Tilley Drive in the afternoons, and now we're expanding to more time as well. And then the last thing that we needed is we needed to have someone in the gym. We needed to have some sort of athletic trainer to help with individuals who were working out in the gym. And so the Victoria Buffum Foundation was our first seed money to pay for salary support to get the program up and going. And so what we did is we really tried to model this after cardiac rehabilitation, because cardiac rehabilitation has a good track record. They're very successful. And so we set up a system of referral. We have evaluation of individuals before they enter the exercise intervention and after the exercise intervention. They work out for 12 weeks, and then there's a lifestyle education component as well, because cardiac rehab realized that it wasn't just about the exercise, but individuals needed help with modifying their weight, improving their blood pressure control, and cholesterol levels as well. So our lifestyle education piece is a little bit different. We emphasize weight control and stress reduction, but again, using the cardiac rehab model. The one difference from cardiac rehab is that we do have an increased emphasis on physical therapy, and there's several reasons for that. Physical therapists do have skills that address needs across that cancer continuum. So an individual, and this has happened several times since the program has started, an individual comes in to be evaluated, and we find out that they have significant range of motion problems that need to be improved before they can go to the gym and start lifting weights. And they can evaluate for many different deficits, including lymphedema. And they have some training in providing exercise assessments and can prescribe interventions, but they're also aware of other rehab services. So maybe that particular individual that comes to see us in Onc Rehab is really more appropriate for our falls prevention program. And the bottom one is the most important, and that is that their services can be reimbursed by insurance, whereas exercise physiologist services aren't reimbursed by insurance. And so our two physical therapists that work mostly with the program, Diane and Michael, see individuals, and they have a 1-hour evaluation where they do a lot of range of motion testing, joint strength function, balance testing, which we're finding is a problem with our cancer survivors. And then either they're referred on for additional PT services to address lymphedema, range of motion, or pain, or maybe other rehab services, or they're put into the exercise intervention program. And sometimes we can do this simultaneously. And then there's also a physician evaluation where we summarize the oncology therapy received. We identify if there's any continuing cancer-related symptoms that might need interventions, like pain or cognitive issues. We then determine referrals if needed and help with some of the exercise goals. And then this is what the cancer survivor receives. They have this physical therapy and physician evaluation. And since Susan joined us in May of last year, we started doing exercise tolerance tests. So we are measuring the fitness that she's so passionate about in all of our cancer survivors who go through the program as well. And then individuals receive a relatively personalized aerobic and resistance training program. And so there is both resistance training and aerobics, and the part that's more personalized is how much weight should that individual use to start their resistance training? Do they need to make some modifications because of range of motion issues? Susan helps us determine what level they should be at when they start their aerobic training. And then individuals work out at the cardiac rehab site 2 days a week for 12 weeks. They receive referrals to additional cardiology, a workup or pulmonary workup or whatever they need, and then we have education classes on site as well. And the other thing that we have gained here at the University of Vermont is a living database, because we collect a lot of information on these cancer survivors as they go through the program. And cancer survivors do sign an informed consent that they can be part of the database. And so we have measurements of a 6-minute watt test, the 1 repetition max strength testing I talked about earlier, some anthropometrics, and now we have fitness or the VO2 max parameters. And we also have functional measures of range of motion, strength of shoulders in particular is a problem with breast cancer survivors, and balance. And then we also collect information related to quality of life issues that we know can be improved with exercise, such as fatigue, sleep, other quality of life measures, depression, anxiety. So how do we pay for all of this? So funding for oncology rehabilitation. There is no insurance coverage for oncology rehabilitation. There is insurance coverage for cardiac rehab and pulmonary rehab, but I have not heard of any other program in the country who's using a cardiac rehab model like we are for oncology rehabilitation. And so hopefully in the future this will catch on and there will be insurance, but right now there is no insurance coverage. So we do get insurance reimbursement for the physical therapy and the physician evaluations and for the exercise tolerance tests for the vast majority of individuals. Every once in a while, there's an individual whose insurance is not willing to pay for one of these or one or the other of these. And then through the oncology rehab funds, we pay for it for the individual so that they can participate. And then, so the bottom line is we depend on donated funds to keep this program going. So some of our results. When we opened in August of 2011, we opened to breast cancer survivors only. Not that we're biased in favor of breast cancer survivors, but we needed to have a way to have things a little bit more controlled to see if the whole thing was going to work. So most of the data that I'm presenting here will be about the information that we've gathered since 2012 when we opened it up to everybody. So in 2012 to 2013, there was 178 cancer survivors that were evaluated within the 12 months. 115 started the program, so that was 65% of them. Some of them didn't start because they needed additional physical therapy. Some of them didn't start because they lived too far away and just really wanted an idea of what sort of things they should do at home. And then 100 of those 115 completed the program, so 87%, which is a pretty high completion rate for our cancer survivors. And most of them attended the majority of the sessions available. So there were 24 sessions available. So most attended between 16 and 24. All right, and so some of our data. So strength, the 1 repetition max that we were talking about, so lower extremity is the leg press, upper extremity is that chest press. So lower extremity strength increased significantly before and after the program, and so did upper extremity strength. But that isn't what's so impressive. I mean, any decent exercise program, resistance training program, you're going to have an increase in strength. It would be pretty amazing if you didn't. But to me, this is what was the most impressive. So of those individuals, now this actually happens to be just the breast cancer survivors, but of the breast cancer survivors that we evaluated, 72% were less than the 10th percentile for upper extremity strength for chest press. Less than the 10th percentile. And after the program, that shifted to only 25% being less than the 10th percentile. So what that tells me is that cancer survivors who hit the program, in this case breast cancer survivors, they were pretty significantly weak compared to the general population. And the same was true for lower extremities, although the lower extremities weren't quite as weak. So 68% of individuals at the time they started the program were at less than the 20th percentile for lower extremity leg press 1 repetition max, and that decreased to 34% after the program. There were also increases in their ability to walk, the distance they were able to walk for 6 minutes. And I was actually a little bit surprised at this because most people could walk just fine, but it did seem to increase. And hopefully in the next 6 months or so, we'll have fitness data that Susan's collecting to present as well. And for the most part, these individuals weren't necessarily depressed. They had, some on average had mild depression, so not a really depressed group, but in terms of some quality of life measures to present tonight, their depression scores and anxiety scores significantly decreased after the program as well. So I think there's several advantages to this particular model of providing oncology care. So this could potentially use cardiac rehab sites across the country, and many cardiac rehab sites aren't being used to their capacity, so I think there would be room to be able to include oncology patients as well. It's partially funded with the physical therapy and physician piece, and hopefully in the future it would be funded by insurance or whatever healthcare it turns out to look like. And it's inclusive in terms of it could provide interventions across the cancer continuum and for many different types of cancers. And it can provide a database that we can then use to evaluate the impact of cancer therapy and then the impacts of our interventions. And it really serves as a platform for research, and that's what we're doing here. We're using our oncology rehabilitation program as a platform for translational research. So the test tube sort of indicates that sort of basic science to bench type research, and then we have our oncology rehabilitation program where we can test interventions. And then wouldn't it be great if we could take our knowledge and then disseminate it to other individuals who don't have a cardiac rehab place nearby? And I think Vermont is a great place to do that because of how rural we are, to work at ways to think about how can we disseminate this. So I'm just going to give 3 quick examples of some of the research that we have going on right now. Michael Toth is a physiologist who looks at muscle function. And he's looked at muscle function from the whole body level down to the molecular level in congestive heart failure, in osteoarthritis, and recently completed a small study on cancer patients who had cancer and receiving chemotherapy as well. And what he's found was that at the molecular level, there seems to be a lower number of mitochondria in muscle cells, which was somewhat related to some of his other findings, which included a decrease in the actin-myosin binding of certain types of muscle fibers, and that translated all the way up to a decreased ability to power through a 6-minute walk test. So that's an example of some very basic research, and he has applied for a grant to then now look at an intervention to see if we can change those muscle parameters. And this is Susan's study. And Susan is interested in thrombosis as well. And this is a really, really important topic for cancer survivors because cancer patients have a 12.6% risk of developing a blood clot at 1 year, and 50% occur during the first 3 months of chemotherapy. And if a cancer patient has a blood clot, they have a higher mortality. And so the EXPECT trial, which is Susan's study, is taking a group of oncology patients that are high risk for a blood clot and randomizing them to an exercise intervention during chemotherapy or not. And then she's looking at markers of blood clot risk. And then this is just an example of more of a disseminated type research project. So 67% of breast cancer survivors are overweight or obese, and individuals with excess weight are more likely to have their cancers come back. And weight loss results in changes of biomarkers that would suggest a relationship between cancer risk and cancer progression. So this is a study that we have going on with Dartmouth and the University of Massachusetts, where we're looking at a behavioral-based weight loss intervention that emphasizes exercise for individuals throughout the New England area. So individuals can live distant from from an academic center and still participate because the intervention is delivered online. And our goal really here is to look at feasibility and also to look at changes in some of those biomarkers that might be related to risk of recurrence. And so we have a huge team that helps support this. So I've just listed everybody there, and I don't think I've forgotten too many people. And I know we're running late, and so I think that oncology rehabilitation there's a long road to getting to where cardiac rehab is, but I think that slowly we're getting there. And what I really want to do is provide a special thanks to those individuals who have helped us get this started. So Victoria Buffum Foundation has provided us with 2 grants. Jane Landy, the estate of Jane Landy, provided money as well to help continue to pay for our athletic trainers and equipment that we need. The University of Vermont Foundation in honor of Karen Meyer. So when Karen Meyer retired, she was a vice president here. In lieu of a party and gifts and things like that, she had all of that money funneled to Onc Rehab, and then she herself, when she was getting all of those days that she honestly didn't, vacation days that she didn't honestly take, that all was then funneled to Onc Rehab, the Fletcher Allen Auxiliary. And for the last 2 years, the University of Vermont College of Medicine and Fletcher Allen marathon teams have dedicated all of their fundraising efforts towards earning money for Onc Rehab as well. And so the marathon is on Sunday, May 26th, in some sort of handout that you were given. You were given a flyer for Onc Rehab, but also a way to donate if you are interested. And we appreciate you listening to us tonight, and Susan can join me here and we can answer some questions. Yes.
I have 3 brief questions. The first one is, when you measure time, why do you do it 500 days, 520 days? Why isn't it 1 year, 2 years, 3 years? I mean, that's normally what you see.
That's just how the particular group of researchers decided to present it. So I have no idea. The graphs probably looked prettier that way, would be my guess. So her question is, why did they measure, and I think you were talking about that particular slide about function, 1,000 days, 5,000 days. That's really hard to put it into any perspective. You had 2 more questions, you said.
Yeah, no, I mean, it's normally not an easy
Yeah.
data presented. What is lymphedema?
So that's a really good question. So what is lymphedema? So some individuals with breast cancer develop swelling in their arm. And so if you think about the intervention for breast cancer, if you are taking out any axillary lymph nodes, that's interrupting the flow of lymph fluid back to the heart. And so through daily processes, cells create extra fluid that need to be taken back to the heart, and that's done through our lymph system. And so if you remove lymph nodes and cut those lymph vessels, sometimes individuals develop swelling in their arm because of a backup of lymphedema. So that's lymphedema.
Okay, and what is anthropometrics?
Yeah, that's what are anthropometrics. So anthropometrics is just a generic term for things like weight, height, body mass index, body fat percentages, waist circumferences. So any means of measuring something about the body dimension.
Calibrate me with the MET scale by, like, marathon runners, how far up do they get? And I understand the couch potato is going to be one. Where do marathon runners get, and maybe some points in between? Just
Right, so when we think about, let's talk about a population that is healthy. The population that I study, we found that if you had a MET level, so this would be at maximal exercise, what was that metabolic equivalent or energy cost at maximal exercise when you stopped your fitness test? A level of less than 9 was predictive of cardiovascular events. It was more like 10 or 11 in men, because men have higher fitness levels than women. This is known. So you can't say that what you achieve on a treadmill as a woman has the same risk as what you achieve as a man. So we have different cut points. But we sort of think about 9 for a woman as being sort of that risk cut point, and 10 or 11 for a man. In our cancer population, we've probably done about 100 fitness tests. We've found that I'd be happy if they achieved a MET level of 6 on the treadmill. So we don't really know how that corresponds yet to overall outcomes yet, because we just don't have enough data on cancer populations. You did see that one study that looked at a small subset of breast cancer patients from Lee Jones' study. But one of the things I'm really pushing hard is that we have better numbers of people that get fitness testing. So when you ask me, what should the MET level be across different populations, I can give you a hard answer for cancer, but we haven't done enough in the cancer population to give you normative values. All I can say is that the cancer population has been a lot lower than I expected. For a healthy population, 9 METs is what I would expect. I achieve about 14 or 15 METs on a treadmill when I go. I would say a triathlete probably could get up to about 20 or 21. And a patient that was going for a cardiac transplant would get probably a MET level of 3 or 4. Hopefully that gives you some distribution.
so for the 150 minutes of exercise, what, if somebody was meeting that, what would their MET level be?
Well, that's the beauty of measuring fitness is I personally think that 150 minutes means different things for different people. And so when I give recommendations for physical activity, it is solely based on how well they do on the exercise test. And one of the things that we do, so I'll give you an example. I did a couple of patients today. We measured their fitness on the treadmill, and one person was 30% lower fitness than what they should achieve for their age. And so I'm not going to tell them that they should achieve 150 minutes of physical activity a week, because if they do that, they're probably going to stay at that same level as a healthy person. They need to go higher. We do know that if they exercise train at a percentage of their maximum capacity, so if they do about 80% of what they're capable of doing 3 times a week for 3 months, we know that they can improve their fitness by 10%. And that's what we're doing in Steps to Wellness. So If a lady comes into me or a man and I know that they're 30% below where they need to be, I can say in 3 months after you go through steps to wellness, I think you're going to improve your fitness by 10%. And that's great because that's only 3 months. You have a lifetime to get back to that normal level. So then I can give them very tangible recommendations for them, where they are now, based on what exposures they've had, instead of just saying, go out and exercise for 150 minutes. To me, that's just not good enough. And I'm a very specific person, and so I don't really like to give general recommendations to people. But if I have to, I'll just say, do more than less, and you'll probably be better off. That's about as generic as you're going to get from me.
Go ahead, sorry.
I just wondered about the long-term follow-up plans for this specific program. So if somebody goes through this for 12 weeks, is the 12 weeks kind of meant to be a gauge that they will then be able to continue this on their own, or?
We wish. So a cardiac rehab, I think, also struggles with this. And so when people graduate from the program, we do discuss with them, well, what are your plans now for continuing to exercise? But we know from cardiac rehab that people tend to fall off the wagon, so to speak. And so we did a short interval follow-up of some individuals when he had started the program, and a survey asking them, so after you left Steps to Wellness, what did you do? And the first survey that we got back, the first question was, did you continue to exercise after you completed Steps to Wellness? This person said no. And then the second question was, how long after completing Steps to Wellness did you stop exercising? And her response was the next week. So we know that we have to have ways of helping people continue to be active, and individuals can continue to come out and exercise at Tilly Drive for a very nominal fee. It's like $25 or $30 a month. But that's a component that we'd like to build, but of course we need money and support to do a longer-term follow-up and maybe provide the program for longer.
I'd just like to follow that up. In a percentage of patients, we do follow-up fitness testing. The reason for that is to motivate the participant to improve their fitness and then see did they actually improve their fitness with the program that we initiated. So it's a really objective measure of our program, and it also is a tribute to the patients and the participants that they've actually done their job and improved their fitness and improved their survival, so to speak. But just to answer that question, I don't let them leave the room until they give me a plan. So they have to tell me what they're going to do before they leave their room in terms of finding exercise and continuing to exercise so they can continue in Steps to Wellness. We give them that option. They can continue in just Tilly Drive, which is not connected, so to speak, to Steps to Wellness, where they can go for $35 a month. I don't know of any physical activity fitness program that allows you to do exercise with trainers for $35 a month. It's very cheap. Or a lot of them say they'll go to the Edge. But they cannot leave the room until they give me a plan. And at least that's a first step. So that's where we are.
You have a statement here saying 67% of breast cancer survivors are overweight or obese. What percent of the American population age 50 and above are overweight or obese?
So the question is, what percent of the American population is overweight or obese? 66%.
Okay, 21% difference.
Yeah.
Well, that's not true in the sense that you're comparing apples to oranges, because what we know is that a breast cancer patient that goes under chemotherapy gains about 3 kilos. And so we're talking about weight gain based on their exposures, not comparing a population of breast cancer survivors to a healthy population. That weight gain is what's deleterious. And so whereas we do have a large proportion of our population that's obese in the first place, not only are you coming into a diagnosis with being overweight or obese, you're gaining weight with the therapy, which is only adding to the problem. So that's an excellent question, but I just wanted to delineate kind of what the problem is.
Next question is, when do you do the measurement? Because when you're on the chemo, you don't want to do anything at all, and you're very weak.
So we do the measurements during chemotherapy. So the way the program is available now is individuals can participate during chemotherapy or after chemotherapy. And our goal is to randomize everybody to do that because it's really, really important to prevent that decline in the first place. And so that's a piece that we really think is important to figure out. How can we help cancer survivors who feel, cancer patients during treatment who feel like they can't be active? What can we do to help them maintain as much as they can during therapy? So we are measuring them during and after chemotherapy.
Yeah, and I would just state that I sort of had that reservation myself coming into it from a cardiovascular. As a cardiologist, I didn't know much about the oncology population. I was worried that they would be too fatigued to start. And what I've really found is the patients that have actually done the fitness testing and recommendations prior and during chemo have been very relieved and excited to actually have something that they can focus on and achieve during their treatment. And so I found just the opposite in a majority of patients.
What if the patient is low in weight to begin with?
So that does happen occasionally, and we did talk a lot about excess weight gain, but we have a dietitian associated with our cancer patient support program that for individuals who are low weight in the first place, we send them to that particular dietitian to help with that, because there is a group of cancer patients, cancer survivors, who have low body weight compared to excess body weight. So we just send them in a little bit different direction. And I think you had another question, sir?
Yeah, I've noticed that you make a big emphasis on running and nothing on walking. And on running, you increase your meds quite nicely, but some people cannot run due to leg problems or whatever.
No, I think that's a good point. And one thing I wanted to state there is that, first of all, when we do our fitness testing, one of the things that we recognize is that a lot of people don't want to run in terms of the testing. And so the actual protocol that we use on the treadmill, they don't really have to run. We increase the slope. And so it prevents sort of this issue with, is it really a fitness issue or the fact that they don't like to run? And so our testing is focused on not running, but increasing the slope to get someone to exhaustion. Second thing is, an individual, as long as they're getting to a percentage of their maximum, so let's say that someone needs to get their heart rate up to 130 to really doing something intense, they can do that walking as long as they're going up a hill, or sometimes they don't even have to go up a hill to get their heart rate up to where they need to be. So whereas the data that I showed you is on running, because that's where the data is, I can tell you with 100% certainty that you can get your intensity up to a level to improve your fitness with walking, as long as that walking pushes you. And you can push yourself with walking by doing different types of walking at different slopes.
Is there a particular reason why oncology rehabilitation is not covered by insurance currently?
I think the major reason is that there's just not a lot of data out there, and I think that's the primary reason. And that's the whole purpose of us collecting the data that we're collecting, is in order for us to show outcomes of improvement so that eventually we can take this to insurers and have them consider onc rehab for reimbursement. But that's the primary reason. We don't have enough data. There aren't enough people doing this yet. We're getting there.
How much data do you usually need to have to go to someone to consider something like that?
I wish I knew. Do you know? What did it take for cardiac rehab?
I don't know.
We have a health economist at University of Vermont that we've been trying to get involved in our program to sort of help us with that, because I don't know. I'm a medical oncologist and a little bit of a researcher. But that's a good point. I don't know, but we are trying to get there.
For your patients that will be starting steps to wellness while they're undergoing treatment, should they then anticipate, once they're done, the 12 weeks after that?
Oh, will they get 20?
You may not have reached that point yet where you've had
Yeah.
to think about that, but
Yeah, we have reached that
I
point.
talk about it a lot.
Yeah.
I'd like to let people know.
Yeah, Nikki's one of our big supporters out there. Right now, we've decided that we would do 12 weeks free, and then if someone wanted to continue it, they would pay the $25, $30 a month to continue.
Those 5 people who did that study in '66, how much would they pay for those 3 weeks? I'm just curious. And what's the current rate?
Are you going to volunteer?
What the current rate is, what it's worth?
I don't know the answer to that question.
Yes?
I love the presentation, but the one data that seemed to fall out was the prostate cancer data. Do you have any hypothesis for what is going on there?
Well, one of the main hypothesis, so I have 2 answers to this. Number one, that's not true for advanced prostate cancer risk. And so we haven't studied this in fitness yet. We will. But physical activity does prevent the development of an advanced prostate cancer diagnosis, just not an early diagnosis of prostate cancer. And the reason for that is that, so it does help to prevent advanced prostate cancer. The second reason is, why doesn't it prevent the diagnosis of early prostate cancer? And we think that individuals that are more likely to be physically active or fit are more likely to be screened, have a PSA checked to determine whether they have prostate cancer. So they're higher likelihood of screening, higher likelihood of getting a diagnosis of prostate cancer. One of the important findings of our study is that even if they had that diagnosis, whether it was from more aggressive screening or not, that physical activity or fitness earlier in life protected them from dying from prostate cancer. So I think there's a little bit of a bias in people that are physically active and more likely to be screened. And I think there's important data to be said that physical activity and fitness protects from mortality related to a prostate cancer diagnosis or even a diagnosis of advanced prostate cancer.
The PSA test sort of kind of comes and goes in terms of favor, and it's sort of out of favor at this point. But
Thank you guys so much for coming.